Hello, I am Dr. Joshua
Hello.
Wang.
Hello, nice to meet you.
Yeah,
Amazing.
nice to meet you. So
Excited.
I share my PowerPoint so it can be shown in the screen.
Yes, it's
It's
sharing.
okay. Okay,
Thank you.
okay.
So you will share from your side, sir?
Yeah, maybe later. Oh, I
Later,
test.
yeah. This
Yeah,
is just
test
a test.
only.
Yes, we understand that. So,
Okay.
thank you so much. So, just you sent the PowerPoint and the PDF both, and you will show your PowerPoint by your side. Is that
Yeah,
correct?
yes, I can. I send you the PDF for for fear that maybe my PowerPoint cannot share. Yeah.
I
So
see.
backup.
Backup, yeah,
I
just
send
backup.
to you for
Yeah.
backup. Yeah.
Okay, thank you. So we just keep it. And then now here, Dr. Dan, nice to meet you.
Yeah.
So do you also please test your PowerPoint if you have?
Uh, I have sent a video.
Oh, yes.
Uh,
So you prefer that to show?
yeah, I prefer that to.
All right. The video was sent by PowerPoint data, is that right? Today. So,
And and someone told me that you only receive the PowerPoint but not the zip file, so I send it using another email also.
oh, I see. We do receive the PowerPoint, but at this moment, we don't have the uh, video. Sorry. I think we just
I can also speak.
this
I
one.
can also
This is
speak too if
without.
you don't have the video.
Would you please speak by yourself?
Yeah, I can. I can.
Oh, great, great. Thank you so much. It's very appreciated.
Mm.
Oh, here comes
The
Professor Vincent Wong and also Professor Jingao Fan. Nice to meet you. Thank you very much for
Nice to meet
joining.
you.
Nice to meet you.
Hello.
Thank you so much. So
Hello, Vincent Wang. Nice to meet you.
here are the speakers for today's webinar. So thank you so much. We really appreciate your great cooperation and contribution today. So maybe in a few more minutes, more panelists and the moderator will be joining. So would you please wait one moment? So,
はい。
誰もちょっといらっしゃらなかったので、並べてしまって。So, may I introduce that this is APASL Secretary Izumi speaking. Nice to meet you. Thank you very much. And we have two speakers, and we'll begin the webinar at 5 p.m. at Beijing time. So it means 15 minutes. In 15 minutes, it will be starting. And at the beginning, we show the e-poster with the sound. It's just 30 seconds. And would you please wait a moment until the e-poster is stopping. And after that, maybe Professor Joshua or Professor Sarin, I'm not sure, any panelists or moderator will be beginning the webinar. So, and after that, maybe they will introduce the today's moderators. And after that, would you, today's moderator, would you please introduce today's speakers, Dr. Vincent Wong and Dr. Sorry.
Yes, sorry,
Oh,
I may have missed some information. So we will have two presentations today, and
yes,
I'm going to moderate the discussion with Professor Fan. Is that right?
yes, right, yes, right.
Okay, so
Exactly.
who will introduce the first speaker?
Oh yes, that depends. And then would you
Then maybe we ask Professor Fan. So, Professor Fan, do you want to introduce the first or the second speaker?
It
It doesn't
depends
matter.
you. It's okay for me.
Then maybe I start introducing ourselves, and then I pass to Professor Fan to introduce the first speaker, and then I will introduce the second speaker. How does it sound?
Okay.
Okay. So we'll do
Okay.
that.
Thank you.
Thanks so much. Appreciate your cooperation. So, and then, is there any question at this moment, sir?
No. So Professor Dan will present the first study on Crohn's disease, and then Professor Wang will present the second study on the prediction of liver and cardiovascular complications. Is that right?
Yes, exactly.
Okay,
Right.
that's very good.
Appreciate. Thank you so much. So now we have 30 minutes more, and please relax a little more, and then please keep your access, and please join that in a few more minutes later. Is okay, sirs? Thank you so much. Appreciate. So may I share this testing PowerPoint now? Excuse me. So at this moment, we show the e-poster over. So, Professor Dan, so may we show your PowerPoint from our side, and would you please say next slide or something, so that we would move the slides forward? Or if you prefer to share from your side, it will also fine for us. How do you think, sir?
Dr. Dan, Dr. Wang, do you have any preference?
And I can share by my screen. If okay, I can control
Yes,
the
that would be
yes.
better because otherwise it can be quite clumsy asking people to forward slides for you. In that case, have you both tried sharing your slides?
Yeah, I show my slide. Yeah, I share. Yeah, it's in my.
Okay, excellent. How about
It's
Dr.
okay.
Dan?
Okay.
Dr. Dan, have you tried?
Okay.
I want to test for first because I don't sure whether I can play my PPT while keeping the Zoom share the screen. I want to try first. Can we? Can I?
Okay, we still have time. Yes, please.
Okay. Okay, so there is my PowerPoint. Did you can see?
Not yet.
Oh, so you can see my screen?
You need maybe double hit. Double hit your screen.
So can see? Did my
Not
screen
yet.
have anything?
Not
Not
yet.
yet.
Not
Yeah.
yet.
So is there another solution
Maybe
for this?
you try again. You not
Uh,
drop out.
So when
so
you share, you need to click the right file. Now we can
oh,
see.
okay, okay,
Okay.
okay,
Okay.
Okay, can you
okay,
move the slides? Okay, this is
okay,
perfect.
okay, okay.
And since it may take time, may I suggest that when Professor Fan introduces you, you can start sharing the slides.
Oh, okay, okay, okay. I have, I will. Yeah, I'm.
So don't wait for us to
Maybe I
finish.
just briefly introducing your name and your present topic today. Then
Uh,
you present your slides.
Okay.
And maybe you should finish your presentation on time. We need more time for
Yeah,
discussion.
I'm okay with that arrangement. I'm okay.
How many times for your presentation? 15 minutes?
I have recorded a video and I try it's about 15 to 17 minutes.
Okay, I see.
That's very good.
Yeah.
And Professor Fan, do you want to have discussion one by one or leave all discussion towards the end?
Um, maybe it's good for end of the two speakers. We need more
Okay.
times and more maybe more questions for two
Yes, it may be
speakers.
more flexible. So
Okay.
Hi, Vincent.
hi, Professor Wei, Professor Lau, good to see you.
Yes, hi, Vincent, Professor Wong.
Hi,
Wonderful,
Professor
wonderful,
Lau.
Professor Wei. Yes, are
Hi,
you getting
Professor
better?
Wei, Professor Leong.
Professor, also Dr. Dan.
Eh?
Yes, and Dr. Wang.
Oh, okay, Dr. Wang. Dr. Fan, 见高.
Professor
你这样
Fan,
说
are you
好。
now back in Shanghai?
Yeah.
Oh, I actually just met Professor Fan this morning, and he's now back in Shanghai already.
你刚刚来了香港啊？
哎，不是，
没有，
我们在南京。
在南
南京啊，
京。
哇，Vincent，你这还在南京啊？现在没有这么快吧？行，好的，好的，啊，现在魏教授也来了，等这个 Omata 跟 Professor Sarin 啊，今天我们是要请你们主持一下这个有两个article 啊，那么有两个 speakers 关于这次的 webinar。Isumi, are you here?
Yes, sir.
Yes, great. So
Hi,
you have the slides arranged and the PowerPoints available already?
Yes, sir.
Good,
Yeah,
wonderful,
okay.
wonderful.
Yes, sir. Thank you very much. So we have 5 minutes more. So please wait a moment. And at the beginning, we'll show the e-poster as usual. Here
Good morning,
is
Izumi-san.
good morning, sir.
Hi,
Hi,
Professor
how are
Wei.
you?
Hi, Dr. Wei. How are you?
Hello.
Good to see you.
Wow, so
Good to
nice
see
to
you
see the
too.
president,
Nice to see you.
of Turkey. How is your meeting going on? And
Very good.
yeah, I hope that
Good,
all the air
congratulations.
traffic will not be interrupted at that time.
No. Everything is going well. I think next week I will complete the whole program and send to you.
Wow, you work very hard, so advanced. Wonderful.
Wonderful.
And Professor Wei did a very wonderful job for the Beijing meeting. It's very hard work, very well
Because
conducted.
of the Professor Lau,
Yes.
your support and the God.
No,
Yes.
that's not. It's a collegial effort. More than 6,000 participants. The first is
Yes.
a record. You break all the records. So Professor Omasi has have a lot of pressure.
That's
No,
right.
I think
That's right.
You break all the
Professor
records.
Michi will have more. Sure, sure.
But
I believe.
you see, he wants
I
to have more.
So Professor
I
Saren expect me
believe.
8,000 attendees from Turkey.
Okay.
So
All right.
can you
Wonderful.
understand my pressure?
Of course. I see. Well, that will help your fatty liver.
But you can attract the audience from both Asia and Europe, so you have
Yes,
some
sure.
advantage.
Yes.
Yes,
I do my best, of course.
sure.
So we have a few more minutes to go, and who is already here? And Professor Omata, Professor Sarin is here. Okay. So how is the weather in Beijing, and is it hot in Nanjing? Is okay?
34
Maybe okay.
degrees.
I lay at bed due to my disc, so I don't know what's the temperature.
Okay. All right. Now we have a few minutes to go, 3 more minutes, and this will be recorded and will go to the YouTube by the APASL official channel. Is Omata, Professor Omata is coming in, and Professor Sarin?
I'm covering, so
Yeah, okay.
they're coming soon.
Okay, soon. Great.
So 2 minutes.
Yeah, but the good news is our Hepatology International's the impact factors increase this year.
Good,
I
congratulations.
think, yes, it increased. Yes.
Congratulations.
Congratulations.
No, it's
Congratulations.
Professor Omata and Professor Sarin's work, and with 6,000 abstracts, I'm sure you can have a lot of paper.
Good.
So in 1 minute, may we start?
Yes, go ahead.
Thank you, sir.
Yes, so welcome everybody to this special webinars of Hepatology Internationals, which highlights the most cited papers in the field, and this time is metabolic associated dysfunctional fatty liver diseases. And the chair of this panel would be Professor Vincent Wong and also Professor Fan. And we have two distinguished speakers to present their very important data published already in Hepatology Internationals. So may I pass this to Professor Wong and Professor Fan to chair the session?
Yes, thank you very much, Professor Lau. So I'm Vincent Wong from the Chinese University of Hong Kong, and it is my pleasure and honor to be joined by Professor Fan from the Shanghai Jiao Tong University. So this evening, we are going to have two presentations. So both are publications in Hepatology International recently, and I must say that both papers are highly cited. So I'm quite excited to hear the presentations. Without further ado, I will pass the time to Professor Fan to introduce the first presenter.
Okay, it's my great honor to be co-chair this seminar with Professor Vincent Wang. And The first speaker is from Shanghai Region Hospital. And his topic today is about metabolic dysfunction associated fatty liver disease with inflammatory bowel disease. And is CD or UC. And from his presentation, you can see maybe CD is more important than UC. Professor Dr. Dan, are you ready?
Yeah, I'm ready. So can you see my screen? Can everyone?
Good.
Not yet.
No, not yet. No, can't see your face.
Not yet?
No,
Yeah.
the screen is.
Oh,
Mm.
I will try.
Yes, please try again. Just
Okay.
now you could do it quite well.
Yeah. So is there any? So is there any PowerPoint?
Not
Not yet.
yet.
Maybe double hit.
So
So this is Zoom, and it would be best if you have already got the presentation mode, and then when you share, you pick the biggest screen of your presentation.
yeah, I've shared my big screen. So there have no, and I have tried when
Open up your
the
PowerPoint. Yeah, open up your PowerPoint.
so is this good?
Unfortunately, not yet. So I understand that the secretariat has your slides. So
Yeah.
would it be possible to share from the secretariat side?
Yeah. So thank
Yes,
you, thank you.
please.
Okay.
Okay, so please use the full screen mode.
Okay.
Okay, here we are. So please just say next slide when you are ready.
Okay.
Okay, thank you.
So I first of all apologize for this mistake, and good afternoon, everyone. I am Lin Taodan from the Department of Gastroenterology, Beijing Hospital, Shanghai Jiaotong University School of Medicine. First of all, I'd like to express my sincere gratitude for the work organizers for inviting me to share our research today. It's truly an honor to be a part of this webinar and connect with fellow researchers in this field of metabolic liver disease and IBD. The study I'm about to present was about MAFLD and liver malfunction biomarkers and the risk of IBD. And this is a prospective cohort study. And please turn to the next page.
Next slides.
Yeah, thanks. So let's first a brief introduction about MAFLD. This is a new term for the non-alcoholic fatty liver disease, and this new term has been introduced as it better reflects the metabolic nature as a complex syndrome. And MAFLD and IBD have captured the global epidemiology during the westernization of lifestyle and related dietary habit changes over the last 2 decades. And both disease entities are characterized by the complex and heterogeneous clinical aspects linked to distinct symptoms and organ systems, which on the first glimpse do not have many commonalities in the clinical practice. Next page.
Next.
However, experimental studies indicate a common backbone of IBD and of inflammatory mechanisms in metabolic disease and gut inflammation. This is also applied to the IBD and MAFLD. Both diseases are frequently characterized by systematic low-grade inflammation, and they share a phenotype that is a disturbance of the gut microbiome systems, and considerable similarities of the pathophysiologic characteristic of the IBD and MFD could possibly be explained by the shared environment risk factors that contribute to the development of disease. In fact, our team's previous work has showed that the lifestyle behavior factors have contributed to the development of IBD, and this contribution may much higher than the genetic factors. And this is also can apply to MAFLD, which we have well recognized that the westernized diet has promoted the development of MAFLD. Next page. However, in clinical practice, despite the confirmation of MAFLD IBD comorbidity, there is a lack of direct evidence whether MAFLD affects development of IBD. This is especially true in 2022, the year which this study was conducted. And in fact, only one study conducted in IBD patients prior to this study found a higher prevalence of MAFLD in IBD patients. And it's also true that the preclinical phase of IBD can be latent for up to 20 years, and the metabolic disturbances are at the core of these pathophysiological changes. As the unique metabolic disorder entities, the impact of MAFLD on the development of IBD is to be recognized in a clear time sequential framework. This is why our study was carried out. And the next page. Next page. Let's start with our data foundation. We leveraged the data from the UK Biobank, which is a prospective cohort that enrolled over 500,000 adults in the UK between 2006 to 2010. It offers longitudinal health records, standardized physical examinations, and biomarker classes, which is critical for linking MAFLD to IBD over the follow-up. Importantly, the cohort includes detailed electronic health-related records, which allow us to accurately track the outcome of interest, which is the incidence of IBD, Crohn's disease, which I showed for CD, ulcerative colitis, which I showed for UC. Our study was a prospective design tracking participants from the requirement to the IBD diagnosis, death, or end of the follow-up. Next page, please. And defining the MAFLD was central to our design. We use the 2022 International Consensus criteria, which is the most powerful criteria when this study was conducted. And this was the first IBD in individuals with MAFLD should first meet the diagnosis of hepatotic steatosis, which was assessed by the fatty liver index. This is a validated biomarker index with 91% specificity in UK populations. And after identification of hepatic steatosis, the individuals will be diagnosed with MAFLD if they have following metabolic dysfunctions, which including overweight, obesity, T2DM, or at least 2 metabolic abnormalities. And the second exposure, we included the liver function biomarkers because we think in addition to the metabolic dysfunction nature to the MAFLD, what makes this disease unique is also its characteristics of the decline in liver functions that especially compared to other metabolic disorders like T2DM. So we included 7 liver function markers, including GGT, TB for total bilirubin, TP for total protein, ALB, ALP, ALT, and AST. So next page, please. Let's start with our confount. Over 12 years of follow-up, we identified 2,200 incident IBD cases in our about 400,000 participant cohorts. And we found that participants with MAFLD had a 12% higher risk of IBD, but the real story is in its subtypes. The CD risk was increased by 35%, while the UC showed no significant links, and we also found that MAFLD CD associations were more pronounced in CD with more aggressive disease extent. Next page. So using the BA80 score to assess liver fibrosis, we saw that MAFLD patients with high fibrosis have a 12% higher IBD risk, and even MAFLD without high fibrosis still with CD risk by 15.8%. This suggests that both steatosis and fibrosis contribute to IBD risk, but metabolic dysfunction itself may be the primary drivers. Next page. Let's look at the liver biomarkers. For each one standardized deviation increase, we found that the circulating levels of ALB, AST, TB, total bilirubin were inversely associated with IBD, while ALP was positively associated with IBD, and we did not observe significant associations between the AST to ALT ratio and IBD risk. Next page. After breaking it down by subtype, CD showed a stronger association than UC for most biomarkers, including AOP, ALP, and TB. This suggests that the liver microbiota talk may play a bigger role in CD development. Next page. Next page, please. And yeah, so what about the extreme values? We all know that liver function markers like total bilirubin have associated with bile acid circulation, which was closely associated with the development of IBD, and the total bilirubin also have the antioxidant natures, but extreme high level of total bilirubin also indicate a decline in liver functions and other liver disease. So we also found that the protective association of AST and TB with IBD were only significant in the normal range of the biomarkers. Next pages, please. So next slide, please. So let's to sum up, MAFD is a significant risk factor for IBD, especially CD. Independent of traditional risk factors, liver function biomarkers like ALB, ALP, AST, and TB reflect metabolic dysfunction and decline in liver functions can predict IBD risk. The liver gut axis likely mediates this link with CD more sensitive to metabolic disturbance. Clinically, this suggests that MAFLD patients should be monitored for IBD. Further research studies should explore the targeted metabolic interventions to reduce IBD risk in MAFLD. Next page. So our study was the first study that provides direct link between the MAFLD to the development of IBD. Although our study team did majorly focus on the development of IBD rather than MAFLD, our subsequent work during the 2022 and 2025 still provide some additional findings to these questions for the MAFLD and IBD link. We have quantifying the contribution of other core components of that metabolic dysfunctions and IBD. So we have explored the association between the obesity and the risk of incident IBD, and we found this association could be partially mediated by the high unhealthy metabolism and inflammation. Next slide, please. And we also explored the other core components of metabolic dysfunction, which is the phenotype of T2DM and the impaired blood glucose homeostasis and in relation to IBD. This association was less clear. We found that dietary intake targeting stable and smaller glucose response is inversely associated with IBD. So next slide, please. So at last, we want to thanks for your listening, and we also want to thanks for our working team. In fact, our team was committed to clarify the driving factors and the underlying mechanisms of the IBD at different stages of its natural history, and we are working on the establishment of a Chinese IBD cohort with multi-omics assessment and exposure omic collections, and we have now enrolled 600 participants of IBD with such data, and that is one IBD studies, and we are willing to collaborate with the researchers. And if you have any interest, you can contact our PI Chen, which the email I have attached in the PPT. And thanks again for your listening, and thanks again for the holders and organizers. Thank you.
Okay, thank you, Dr. Dan, for your
Yeah.
wonderful presentations. And we have discussions after the second presentation. And thank you again.
Okay, thank you, Professor Fan.
Okay, thank you, Professor Fan and also Professor Dan. So our next presentation is titled Metabolic Associated Fatty Liver Disease Better Identify Patients at Risk of Liver and Cardiovascular Complications. So this is based on the Taiwan Biobank cohorts, and the authors included Dr. Yuming Chang, Dr. Chachi Wang, and also Professor Jiahong Cao. And this presentation will be given by Dr. Wang from the Chuchi Medical Foundation and School of Medicine. Dr. Wang, please.
Okay. Thanks for the introduction of Professor Vincent Wang. I am Jiaxu Wang from Taipei Tsuji Hospital. Today, my topic is metabolic associated fatty liver disease, better identifying patients at risk of liver and cardiovascular complication. This is the background. A nomenclature of metabolic associated fatty liver disease, MAFLD, with a new definition was proposed in 2020 instead of the previous NAFLD. However, whether it better cohere with the clinical demand remain controversial. This is the diagnostic criteria of MAFLD. It has been mentioned by previous speaker. So briefly, one is hepatic steatosis, and the second is metabolic dysfunction, including three conditions. One is overweight or obesity, the second is type 2 diabetes, and the third is the specific lean and normal weight patients. In our previous studies, around maybe 10% in NAFLD patients. The MAFLD has increasing importance because after the development of effective prevention and the treatment for hepatitis B or C viral infection, MAFLD is the leading cause of chronic liver disease. Its high prevalence, 20 to 50%, continue to rise in parallel with the endemic of obesity and diabetes. Our previous study from the Taiwan Biobank showed the prevalence of MAFLD is 38% in Taiwan. MAFLD patient has an increased risk of mortality than the general population, and the top three cause of death. The first is cardiovascular disease, the second is non-liver cancers, and the third is liver-related disease. This slide shows the material method. The participant with fatty liver on ultrasonography in Taiwan Biobank cohort was included. The severity of liver fibrosis was associated with the prognosis of liver-related disease. So we used the FIFO index and the nephropathy score in our study to represent the severity of liver fibrosis. And This slide shows our study focused on the clinical characteristic and outcomes about the metabolic factor such as BMI, waist circumference, glucose, and lipid metabolism. And the second is cardiovascular disease risk. In our cohort, we have the carotid duplex data. So we use the carotid intima median thickness and the carotid plaque to diagnose the atherosclerosis and represent the cardiovascular disease risk. And as previous says, liver-related disease risk, we use the fibrosis FIFO and the nephropathy score. I briefly introduce the Taiwan Biobank dataset. In Taiwan, since 2008, the participant was enrolled through 43 recruitment stations. After obtaining informed consent, a formal questionnaire including pastry, smoking, drinking, diet, work, and exercise was performed by an experienced nurse. The demographic clinical laboratory data was collected, and the sample of DNA, blood, and urine was optional obtained. After all the participants were invited to receive a follow-up at the interval 2 or 4 years, and at the first follow-up, the participant will receive additional examination, including abdominal ultrasound, bone mineral density measurement, and the carotid duplex. This slide shows the definition of NAFLD and the MAFLD. NAFLD is defined as fatty liver in the ultrasonography. Without the hepatitis B virus or hepatitis C virus infection, alcohol, or other non-cause of chronic liver disease. And in our study, participants with persistent alcohol intake, more than 210 per week for male and more than 140 grams per week for female, with a period of at least 3 months, was excluded from the diagnosis of NAFLD. This is the result. A total of 9,700 subjects. The mean age was 55.9 years old. They was divided into 2 groups. One is overlapping group. Based on the diagnosis of MAFLD or NAFLD, if has both, it is termed overlapping group. And if another is NAFLD only, and the left side is MAFLD only, and neither fatty liver disease group, total 4 group, and the percentage is 80% in the overlapping group, and around 12% in the MAFLD only, and 7% in the NAFLD only. So this table shows the comparison of clinical characteristic and outcome between MAFLD and the NAFLD. So we can see, compare with the NAFLD patients. MAFLD patient had a great percentage of male, higher level of BMI, waist circumference, HbA1c, and the triglyceride. In addition, they had higher level of serum ALT, AST, gamma GT, fatty liver index, nephropathy score, and the intima median thickness, but no difference in FIFO score index and the percentage of carotid plaque. But we know that the two group, 80% is overlapping. So we can see the shift from NAFLD to MAFLD. We can see the NAFLD only group means had hepatic steatosis, but without metabolic dysfunction. During the shift of diagnostic name, this is a missing group. And another is adding group, is MAFLD only. it has hepatic steatosis and metabolic dysfunction and concurrent with other liver disease, such as viral, alcohol, or autoimmune hepatitis. And the overlapping group is hepatic steatosis, metabolic dysfunction, and exclude other chronic liver disease. Okay, so this table, we comparison the missing group and the adding group because the 80% overlapping is the same populations. So we see that their clinical characteristic and outcome, is there any difference? So we can see the MAFOD only group had greater level of AST/ALT, gamma GT, fatty liver index, FIFO score, nephropathy score, intermediate thickness, and a higher percentage of keratic plaque than the NAFOD only group. This slide shows the limitation of our study. So in our study, fatty liver was determined by ultrasound, but not histology. Furthermore, ultrasound-based studies show poor diagnostic accuracy of fatty liver when hepatic steatosis is under 30%. And in the dataset, the high sensitivity C-reactive protein and the insulin resistance were not available in our study. So the prevalence of MAFOD might be underestimated. And the risk of cardiovascular disease was indirectly assessed using the marker of atherosclerosis, not directly from the actual event of cardiovascular disease. As we know, this is the change of nomenclature for hepatic steatosis. NAFOD was first introduced in 1980, and 2020, the MAFOD was proposed to replace the NAFOD, and 2023, the AA proposed the MASOD, the diagnostic name and the criteria. This is our perspective published in JFMA. I think the achieving global uniformity between MAFOD and MASOD is very important because it is better for future communication and liver researchers. And I think MAFOD has its strengths, such as MAFOD. MAFOD is a broad sense definition, so it is better for clinical practice. In our study, the overlapping group, this is a pure MAFOD. So the abbreviation can be P MAFOD. I think this group, pure MAFOD, is better for liver research. And another MAFOD only group, this is concurrent MAFOD. We can use the abbreviation C MAFOD. And the MAFOD is equal to pure MAFOD plus concurrent MAFOD. And I think the MAFOD is better for clinical practice. I think these two terms may be better for future the standardization of between the MAFOD and the MASOD. This slide shows the conclusion. MAFOD is an inclusive diagnosis with the mention of underlying cause, which make explanation and education easier between physician and the patients. And our large-scale population-based study confirmed the change of nomenclature and diagnostic criteria from NAFOD to MAFOD, which could identify more patients at the risk of metabolic, liver, and cardiovascular disease complication for early intervention. Therefore, our findings suggest MAFOD may be a better nomenclature in NAFOD in clinical practice. Thanks for your attention.
Thank you, Professor Wang, for your excellent presentation. So these two papers are now open for discussion. So we have an excellent panel of experts here, and the audience may also use the chat function or Q&A function to ask questions.
I can ask a question,
Yes,
Vincent.
please,
This is
Professor George.
yeah, it's to Dr. Wang. I think it's a great study, and the interesting thing was it was published back in 2023, so a couple of years now. And I think what it does show is that, you know, the underlying disease is actually associated with metabolic dysfunction. And I think it's gone a long way to try and look at a group of patients that are at risk of long-term adverse liver-related outcomes. And I think that's the main benefit. And I think there's been subsequently quite a few studies looking at sensitivity and specificity, because I think if you look at the any data anywhere in the world, if you look at all patients with liver fat, then you know, NAFLD, MAFLD, MASLD, whatever you want to call it, you then end up having a huge group of patients, but a very small pool of concerned hepatologists. So you want to be able to try and find the guys with high risk. And that's where the definition actually becomes very, very useful. So I just congratulate Professor Wang for Dr. Wang for his study. And I think his is one of the studies. There's another Korean study and several others. All of them have actually shown that the definition, because it gives you cardiometabolic risk factors and more severe metabolic dysfunction, it just highlights the fact that it is a more appropriate definition. So congratulations.
Thank you, Professor George. So if I may, I would also like to ask a follow-up question. So in your study, Professor Wang, the interesting thing is that you defined the patients using the contemporary method definition, but you also nicely discussed that it is actually a combination of two groups. So one with a pure method without concomitant liver diseases, and another group with concomitant liver diseases. So in particular, viral hepatitis and excessive alcohol consumptions. So did you look into the cardiovascular risk factor and also liver markers between these two groups?
Thanks to Professor Vincent Wang question. In our slide, the table 2 show the comparison between the okay. So
Yes,
you
but
yeah.
this is pure method versus pure no, it is method versus pure method. But what I'm asking is the influence of concomitant liver diseases.
Okay. From our study, we did not analyze your point, but I think it's a good question. I think it's a good question. But then maybe I can do further analysis about the two group. But the cause is different. One is concurrent. I think maybe concurrent is more severe. Yeah, because it has metabolic dysfunction and combine other disease. Yeah.
Yes, I believe so too. And it also depends on which endpoint you are looking at.
Yeah. Mm.
And I think a Korean study has actually confirmed exactly that, Vincent.
Yes. Okay, Dr. Dan, maybe I'll also ask you some questions. So
Okay.
this is very interesting. So first of all, I think many people would like to know why Crohn's disease alone, but not ulcerative colitis. So do you have any idea about the difference between the two types of inflammatory bowel disease?
Okay. We actually we can well, after we finish analysis, we'll have several internal discussions about that. First will be the disease extent of the two subtypes. So we all know that ulcerative colitis often occur in the colon, and the CD often occur in the small intestine. So the difference between the microbiota may be also an explanation. And a paper, and we also noticed that some experimental paper also shows that a high level of metabolic dysfunction, especially impaired blood glucose, were also associated with a relatively low grade of inflammation in colitis. This is, however, this is conducted in animal studies, so this may not apply to human. So the distinction between these two can also be explained by some other cohort studies, because we also found that in some large scale population studies such as EPIC, UK Biobank, and Nurse Health study, they found that some metabolic dysfunction phenotypes such as obesity were more likely to infect CD rather than the UC. So I think this can explain some distinction between the CD and the UC. Yeah.
Yes. So the other discrepancy that we can hear from your presentation is between our classical liver enzymes of ALT and AST versus alkaline phosphatase. So in fatty liver disease, we quite often see ALT and AST elevation. However, in your study, the association with Crohn's disease was mainly observed for ALP, but not for ALT and AST. And we also know that ALP can come from the bile ducts, but it can also come from elsewhere, notably from the bone and also the intestine. So do you think it is non-liver ALP that is driving the association with Crohn's disease?
Oh, okay. So this should, I think, should combine with other results. So you can see that when we investigate the fibrosis risk association between MLFD with high or low fibrosis risk with CD, we found that MLFD with a relatively low fibrosis risk were associated with a higher risk of IBD. With CD, that is 18%, and the MFD with a high fibrosis with risk with CD was about 32%. So the difference will maybe indicate that it is metabolic dysfunction rather than the decline in liver function that drives the development of CD. So I think this may be the explanation for the results of liver biomarker analysis, and we'll also have another analysis that shows the extreme level between the liver function biomarkers that was not associated with CD anymore, with IBD anymore. So I think this also match the idea of the MFD in replaces of NFLD. It highlights the nature of metabolic dysfunction rather than the liver function. Rather than liver function, maybe it more important in the preclinical stage of IBD or CD.
Yes, this is very interesting. And Professor Josh has a comment.
Yes, this is very, yeah.
oh.
Sorry. Jacob, you go ahead. I will follow.
Yeah, look, I was just interested. I'm not that much into the literature on IBD and fatty liver disease, but yours is looking at patients with fatty liver disease, MAFLD, and then looking at the risk of Crohn's disease and IBD. Are you aware of studies that look the other way? So patients with IBD or Crohn's, do they have an increased risk? So which way does the direction go? Does IBD give you the MAFLD or the other way around? And perhaps, you could actually look at it with, and if there was an association, you could look at genes that are linked to IBD. And, you could do some looking at whether those genes increase your risk of fatty liver, for example, to try and work out which way the causation runs. Because, in patients with IBD, a lot of them are on steroids and other drugs that may end up giving you steatosis. So do you have any idea about that, the reverse way?
Yeah, I think this may be a this may be a direction association such as this may be also applied. This may be an example. The muffled IBD association may be also like the IBS link celiac disease. Maybe this be paralyzed examples. So there is a study also showed that the patients with IBD have a higher prevalence of muffled, and they have and patients with IBD are also at the high risk of advanced liver disease such as like liver fibrosis, and this have a much more research into the IBD patients have a higher prevalence or higher risk of MFOD. And since the IBD have many extraintestinal manifestations, including the liver disease, so I think IBD will promote the MFD, but they can be also applied that MFD will approach the development of IBD. First, our study is a longitudinal study with 12 years follow-up. I think this time lag also have some power to prove that MFD will also infect IBD. And there is another study using Mendelian randomization, which in the methodology maybe strengthens the causal inference that shows that the diagnosis of NAFLD are associated with increased risk of IBD. So I think this may be a direction or both direction of the association are reasonable. Okay.
Thank you. Thank you.
Yes, so indeed, I have read many papers talking about the high prevalence of MEFOD among patients with inflammatory bowel disease. But Dr. Dan, I must say that this is the first paper I see that you are talking about fatty liver as a risk factor of subsequent Crohn's disease development. So congratulations. I think Professor George's question is very important. And theoretically, since we now know a number of gene polymorphisms associated with both fatty liver disease and also Crohn's disease, so theoretically, we can do Mendelian randomization studies both ways to interrogate a potential causal relationship between the two from both directions. Professor Lau, you have a question or comment?
This is a very good discussions, and it's really exciting to learn the new informations and the directional development. My question is, do you have a chance to have a liver biopsy in some of those patients? Because we talk about ductal enzymes, and we have raised questions whether the ductal enzymes or the alkaline phosphatase is actually related to the bile ducts or elsewhere, and whether you have an opportunities to look at the possibility of autoimmune disease in some of those patients linking to the liver disease itself, rather than just the muffled with Crohn's.
Okay, so it's for if you want to investigate the association between the MFD and the development of IBD, so it's also acknowledged that it's golden standard for the to do liver specimens, and rather than the biomarker index used in our studies, but there may be some challenges because one study you need exposure group and control group, and we cannot do liver specimen in control group, and I have actually, where our team have do some other studies into the NAFLD, that is, we conducted a systematic review between the folate level and NAFLD risk. This is published in the American Clinical Journal of Nutrition, and in that systematic review, we included 13 study, and we found that there is no difference between the level of folate with the NAFLD diagnosed by clinical criteria diagnosed by ultrasound, diagnosed by biomarkers, or diagnosed by the liver specimen. So the diagnosis methods of NAFLD may not very is an important factor, but they may be not the driving factor that affect the exposure and outcome associations. I should admit that the liver specimen data is very valuable and will advance in our understandings, but technically this may be challenging and costly in to do such study only to replicate our findings. This may be so expensive.
And Professor Wang has a follow-up comment.
Thank you. Really, we do not do the analysis between the concurrent MAFLD and the pure MAFLD. But because concurrent MAFLD may be too many causes, such as HBV, HCV, or alcohol. But our previous study had been published. We compare concurrent HBV and fatty liver compare with MAFLD, and we can find if we have two disease, the liver disease severity will increase. But in the atherosclerotic risk, maybe HBV has protective effect. But another study about the concurrent HCV and the MAFLD compare with the MAFLD, pure MAFLD, the two risk, the liver risk and atherosclerotic risk all increase. Yes.
Thank you, Professor Wang.
Hi,
Professor,
Professor Wang.
yes, Professor Wei.
I have two questions. Yeah. And
Yes, please.
okay. Sorry, I cannot find where to indicate my raise my hand. So I raise my hand here. Okay. And the first question and the to Dr. Dan. And the so, and did you have in the follow-up of the patient's data to know and doing the follow-up and which and the MAFLD patients and what and the parameters, what cut off could be and helpful to predict and you see, or also an other way and a baseline the patients with and you see and with some specific parameters and specific cutoff, then develop to the MAFLD, then we can know and which patients we should focus follow up.
Oh, actually, we did not analyze such an issue during our analysis. So I think this is a good idea to recheck this issue. I think this will contribute to the validity and added more information to our findings. Thank you.
And Dr. Wang, thank you, Dr. Wang. Can I have a question?
Yeah, please.
Okay. And your paper and the just report and the 2 years of follow up. After all, and you have the more time, longer time follow up. And actually in the metabolic cardiometabolic risk factor was associated with MAFLD diagnosis some 1 years in the criteria. And however, it's at a baseline. So the long-term clinical outcome in liver, including cirrhosis and some also HCC or decompensation. So, and do you have any data which in the cardiometabolic risk factor is associated in the long-term outcome? So therefore, maybe someone associated, maybe someone did not. So therefore, I think we can improve the criteria for diagnosis. pick up someone to predict the long-term liver events. So do you have any data?
Okay, thanks for your question. In our study is a cross-sectional study because the Taiwan Biobank he has baseline data and the first follow-up and the second follow-up till now, only second follow-up. But the first follow-up will receive ultrasound. So in our study, we use the ultrasound finding to diagnose fatty liver. So we use the follow-up, the first follow-up participant to do the analysis. So I think the long-term outcome is very important. But the second follow-up, the patient is still limited. Maybe I will wait the number increase and I will do the cohort to see the any factor associated with worse prognosis. Thank you.
Thank you.
May I have a question?
Yes, of course, please.
First, I would like to thank both speakers. Very nice speak. So my question is that I believe in that gut microbiota make a very important role for developing of the MAFLD. So if we treat the Crohn's disease, such as, like said, the biological agents, then how is the clinical spectrum becomes better and better? For example, type 3 fibrosis became type 2 fibrosis or F1 type 2 fibrosis. So is there any data about your study?
Oh, so thanks the professor, and actually we did not have such microbiota data in our studies, so this will be an great limitation that we cannot involve the microbiota data when we investigate the association between two digestive disease. And I think the new technology will compensate and help to answer some questions because the new genetic data have shown that our host genetic variants are associated with the abundance of several of specific microbiota species. So we can calculate the polygenetic score to predict the abundances of specific microbiota of individuals and investigate the interact with the MAFLD during the development of IBD. I think this is a good supplement to our current findings. Thank you, Professor.
Thank you.
And Dr. Dan, to add to your practical message, have you looked into the effect of metabolic treatment on the incidence of Crohn's disease? So, for example, the use of statins, some anti-diabetic drugs. So, are they associated with a lower risk?
So yeah. So I did not investigate in this study, but there is some data. So first for statins, the last year we have published a paper in clinical gastroenterology and hepatology that titled dietary antioxidant capacity and risk of CD. And in this study, we have investigated the interaction of statins. Actually, there is a study that shows that intake of statin was associated with the lower risk of IBD. But the main discussion by this paper, also by our papers, indicated that the statin have not only the effect of lowering lipids and improve the blood lipids homeostasis, also they have an antioxidant nature. So we also found that if you and we also note the significant interaction between the studying use and the dietary antioxidant intake in the IBD. So some anti-metabolic dysfunction medicine can have their effect, but it may not have their effect in a way that anti their primary metabolic dysfunctions. And for the anti-diabetic drugs, there is some network meta-analysis that show GLP-1 and DPP-4 that's their association with autoimmune disease, but I can't give a conclusion for that because currently I did not remember that result. But I know there is some systematic review have elucidated such association with autoimmune disease. Thank you, Wong.
Thank you, Dr. Dan. Professor Fan, you have a comment?
Okay, thank you. Wonderful presentations and wonderful discussions. In this seminar, I learned much because metabolic dysfunction and all fatty liver disease are risk for increased IBD, especially CD, and cardiovascular disease. Therefore, maybe we should pay more attention to metabolic dysfunction as well, instead of focus on fatty liver. In my opinion, the other aspect may be about advanced liver disease, the impact of advanced liver disease, especially advanced fibrosis, on the risk factor for increased IBD and cardiovascular disease. Maybe it's very complex. We have a lot research need to do. Thank you.
Thank you.
Thank you, Professor Fan. Are there any other questions? So on that note, I'm sure you will all agree with us that we have very exciting presentations followed by the very interesting discussion. So I would like to thank both speakers again for the excellent presentation and also for the panelists for the insightful comments. And thank you all for your active participation. And I look forward to seeing you all in future APASL webinars. Thank you.
Thank you.
Thank you.
Thank you very
Thank
much.
you.
Thank you very
Thank
much.
you.
Excellent. Thank you.
Thank you.
Thank you.
Bye-bye.
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 Thank you so much, professors.